I'd like to invite Pooja up onto the stage, please.
So we're going to be focusing on a really important issue that's happening kind of in A&E with a lot of people in suicidal crisis who end up in A&E. For some people, it might be their first place for attending. Others may have been in primary care or other areas as well. So one element that this study is part of is that we've noticed within research that there's not some kind of accurate coding for suicidal crisis in A&Es. There's coding for people who come in and harm themselves, and all of it kind of gets put under self-harm, but there's not actually coding for people who come in crisis who may not have done anything physical to themselves. So that's kind of what's driven this research. And we wanted to ask, because we're always hearing about kind of negativity from people's experiences of attending A&E with staff and feeling quite judged and, you know, it not being necessarily the right place for them to go in suicidal crisis. So we wanted to explore this further, and that's why we did a piece of research looking at some of the staff perspectives and kind of what some of the issues are that might be driving this. So one element that we found when looking at the literature after doing a systematic review, or Molly doing a systematic review, is lack of training, which won't be surprise to people, and the lack of kind of clinical guidelines to support staff with suicidal crisis presentations specifically. So when people are coming in and just communicating how they're feeling, a lot of staff weren't kind of prepared on how to manage this and where this group might be referred to. Then there was a lot of systemic issues to do with the lack of resources and staff, especially if we're thinking about nighttime, when the staffing may go to one person on certain areas of the hospital, and also lack of beds to put people while they're waiting for an assessment. And because it's not a physical issue, then it's treated slightly differently. And then also just the kind of fast-paced emergency department environment, and that sometimes it's not a relevant place for people to be who might be in a crisis, and they may leave because they're seeing all these other physical health issues coming through, but also the kind of resulting staff burnout and compassion fatigue. And in other research I've been involved with as well, a lot of patients are talking themselves about seeing staff burnout and actually having a lot of compassion for the staff because they can see this happening around them. So that's just a little bit of the background, what we're finding in the literature. So Molly's going to go on and just speak about what we did.
Yes, so touching on what Pooja's just said there, is that there was a real absence of qualitative research in the literature. There was a lot of quantitative work, but quite an absence in terms of hearing staff's actual perspectives and what they're experiencing and what they're feeling. So I conducted semi-structured interviews with 23 staff. And again, in the literature, there was a real absence of staff who came quite early in the pathway. So despite emergency department reception staff being a person's first contact with the service and this contact being really detrimental to progression through the service, there was no research actually recruiting emergency department receptionists. So that was a key factor that I wanted to address. 8 interviews were conducted online, and this was sort of in the midst of the COVID pandemic, but I was quick to notice that this was sort of the higher level consultant staff who could afford me their time, and again this was sort of not really addressing some of the key gaps in the literature. So when I was managed to sort of worm my way into a few emergency departments, I managed to recruit some of the sort of reception staff and the triage nurses. So yeah, we sort of looked at their views about their training, do they think they're adequately equipped to support people presenting suicidal crisis, and this was really focusing on the crisis, so not people presenting who don't necessarily need any physical intervention, and then sort of what factors influence their decision making as well, and then I analysed the data using thematic analysis. So the first theme that came out looking at the factors that influence staff decision making, and this centred around the lack of confidence, training and risk-averse practice. So staff described a lack of confidence regarding talking to patients about suicidal crisis and self-harm, with some staff saying that they don't really know how to ask the question, so they would just sort of avoid it. And then this was linked to partly the limitations in the lack of training for staff around this topic. So staff discussed the need to implement training for all staff, not just those who are having that face-to-face contact, for all staff, including the reception staff as well. So staff described feeling anxious, wary and fearful regarding the decisions for this patient group in particular, due to the discharge and the potential risk around the discharge as well, and staff not being able to guarantee the outcome for patients and that sense of needing to protect the NHS trust as well. So across all staffing issues, this was a big issue that was discussed, particularly in relation to the emergency department staff, because we have a mental health team who are commissioned to take the risk, as that final quote on the slide says. The second thing that came out, the second sub-theme, was related to the unavailability of resources. So lack of beds contributing to poor flow, and this resulting in difficulties providing adequate care for patients in suicidal crisis. So staff often discussed feeling quite conflicted in their decision making, so wanting to support patients in the least restrictive way while still recognising the pressure on services. And staff often discussed the high workload combined with waiting time targets or staff shortage, which impacted on their decision making. And staff did feel that they didn't have enough adequate manpower to discuss trauma in a psychologically safe way. And then the final sub-theme related to negative emergency department culture. So staff often describe their own attitudes towards patients in suicidal crisis in a positive way, describing their views as empathetic, compassionate and understanding. However, terms such as attention seeker or cry for help were also used, and this was particularly in relation to self-harm presentations. So this inherent perhaps unintentional use of negative language was evident across all staffing roles. And this seemed to stem from higher, perhaps older management structures, and these views being trickled down into new junior staff, and then that cycle of a negative emergency department culture continuing. Then the second theme looked at the factors that influence quality of care, and this was looked at in terms of both the staffing member as well as the patient as well. So the fast-paced emergency department environment was discussed in relation to staying up to date with referral pathways, particularly during COVID, as well as available community service and follow-on advice. A positive that was discussed by staff was a side-by-side initiative in which mental health liaison services would work closely with general hospital staff. But this was sort of discussed quite inconsistently across sites in terms of what was being able to be implemented within that emergency department site at the time. Emergency department staff also reported increasing role overload as a result of staff shortages and increased patient numbers as well. So the impact of working environment stresses was sometimes increased by staff autonomy, and this was inconsistently applied across sites. The desensitisation to suicide was also worsened by long shift patterns and staff feeling morally distressed. And then finally, the final theme related to staff burnout, mental health and well-being. So emergency department staff discussed feeling emotionally exhausted in terms of supporting people who are presenting in suicidal crisis. And most notably, emergency department staff reported feeling really concerned about how they're addressing patients' needs, and felt that they were perhaps rooted in more broader societal issues that were perhaps out of staff's control. There were also sort of a relation in terms of staff working particularly alone at night when perhaps there are higher emergency department presentations, and staff feeling really scared to take that risk, which had a significant impact on their own well-being as well. Staff did speak really positively about their team. So there was one team that I interviewed that was a really strong mental health nursing team, and they really discussed how their positive relationship really helped, particularly during the pandemic, and how they could all rally around each other and support each other, particularly when addressing people who are presenting in suicidal crisis. And then finally, staff retention and recruitment. So high workload, staffing pressures, burnout and poor resource availability were linked with job dissatisfaction. So many staff discussed the potential for early retirement or moving from a clinical role into a more academic role, as they felt like they couldn't make a difference or make a change anymore. I also interviewed some mental health nursing students, and they discussed how they didn't really feel like they had specific support for dealing with suicidal crisis patients from their university course. They felt like it was quite generic and they wanted more specific training at the earlier stage as well. Do you want to take over from here?
Okay, so one of the elements we were asked to think about is, well, you know, the kind of so what. So we've done this research, we've asked the staff what they think, and what's been really good is one of the supervisors on Molly's PhD actually worked within one of the mental health trusts as well. So we had like a really close relationship all the time, and they were always asking Molly to come in and present her work throughout the process. And we've worked with them to think about, well, what are some of the recommendations for staff and what can we do with this? So one of the elements is definitely to address the negative language and the ED culture. And what some of the staff talked about is, even if they came in with this real positive attitude, this kind of historical kind of vocabulary that's used, and eventually they start picking it up. So it's about changing that culture as well, and this being included within the training for all of the emergency department staff, down to kind of people who are at the front desk when people are arriving, because that can be one of the most crucial conversations, actually, is the first conversation that people have. And then this cathartic nature of research, but also compassion. I think that comes up all the time, about just being spoken to with more compassion, and staff speaking with more compassion as well. But due to their own burnout sometimes and their own pressures within the system or the time of day, you know, we had staff saying that if it was the first person I saw on my shift, it'd be very different to the person I've seen 12 hours later, potentially. So thinking about things like that, of how long people should be working as well for their hours, to be able to keep that and not have fatigue as well. Or we need to do that one. So one thing we thought about is the language alternatives and how we could incorporate this with some of the training that does take place with mental health nursing staff and ED staff in some of the mental health trusts. So it's about changing some of the language. So some of the negative language that was brought through again in this study, which has been brought through historically. So attention seeker is something we've heard about a lot, but just turning that into the fact that someone's help seeking. And that's something we want people to do, especially if we think about men who are at real high risk of suicide. You know, one thing that comes out in the literature is they don't seek help enough, but actually a lot of them are help seeking, but they may be being termed as attention seekers if they do step through the door. Or for people who maybe have self-harmed many times, there's a lot of the time they might be labelled with the term attention seeker, but it's actually thinking about why they coming and help seeking, and what has led to the self-harm. The second term we hear about a lot is people having a cry for help. And it's the way I think it's used in a negative context, because if you think someone's having a cry for help, that could be seen as, okay, we need to help them. But it's actually making someone feel like the fact that you can see that they need help, rather than you're coming in and doing something for attention. Again, it kind of comes back to the first point, is the way the term is used. So letting people know who are coming into emergency departments for crisis that may not be for physical health, that you can see that they need help and that they're not being judged about that. This is a term that's come up a lot. It always still seems surprising that in 2024, 2023, that it's still happening, but even within the interviews, you know, people could have stopped if you wanted to, and some of the service users we've interviewed as well have still spoken about this quite recently. So again, changing that language of we need to understand what leads to self-harm. And we've been working on other research in our group on brief psychological models for people who come in touch with services in crisis, who are seen within 48 hours and then get brief psychological models. And I think the fact that the focus is on about what led up to self-harm or what led up to the crisis is really helpful, and that's what we're seeing through our research. It's a lot more beneficial, and it's giving some credibility for the reason of why they're coming in and asking for help in the first place, rather than using this negative language of you could have stopped this, you know, and you didn't need to do this, or you've done this again. So it's just changing the way that that's coming across. And then people being told that they're wasting time and resources. And just, you know, yes, A&E and emergency departments are kind of a very busy place and a place that needs to be used correctly so that everyone can be seen. But it's trying to explain to people that there might be other points of contact that they can have if they're in a crisis again, rather than making them feel like, you know, they're just wasting people's time. And there are actually some really good services available. Some of the crisis teams are doing some fabulous work, but it's people not knowing even that there is a crisis line that they can now phone, or knowing that they could have contacted the crisis team directly as well. So there are implementations that are happening that are really good, but I think it's the language that needs to be improved alongside that. And then just about the impact. So we're very much, I think, applied health researchers in our group, and just thinking about where we're presenting this research. So we make sure that we present it at kind of all arenas, whether it's regional, like today, national, international conferences, and also in the NHS in their own events as well. We've been really fortunate that they've welcomed us into all of our kind of local NHS trusts. And being members of some of the wider steering groups to do with the NHS or to do with public health really helps us feed our research into practice. And when they're commissioning some new kind of ideas, we've been brought in to then help with the training. And Molly's been really fortunate. She's been invited along when they've been actually, you know, creating new bespoke training for some of the mental health staff, which has been brilliant to see that. And that was before the end of the PhD, which has been fantastic. So as a direct result, we've had some emergency department administrative staff now taking part in mental health training, which didn't happen before. And hopefully that's something that will be rolled out wider. So I think that's everything from us today. Yeah.
Thank you.
Thank you.
Thank you for giving us time. So that last slide brings me to a point, and I've got the implementation support team over here on this table, and I think there's a real opportunity for your research group and the A&E researchers to come together and talk about developing an implementation project with our impact team to bring some of these findings into a way that we can spread across North West Coast A&E departments, bring into training, bring into the wider team training. It's so disheartening for me to hear the same negative comments I was challenging 40 years ago, working in casualty as it was, and saying to some of my colleagues, I sincerely hope none of your relatives ever come into a casualty department and hear somebody talking to them like you just did to that patient who's been attempting suicide in the disparaging, negative, aggressive way that you did. You're wasting my bloody time, and those sorts of comments that were made. I'm sick of people like you. It doesn't sound very sadly like it's changed much. And sadly, anecdotally, as a GP, I've had patients who sat 24 hours in A&E waiting to see somebody after a suicide attempt and have given up and come home, and they've been offered a 2-week crisis appointment. So we pick them up in general practice and put the wraparound care as well as we can. I know that's an exception, but it still shouldn't be happening. And I may have got the data wrong, but my understanding is that for young people at least, this is one of the highest risk factors for death, is attempted suicide. That the risk factor for that person being dead within 5 to 10 years is significantly greater than almost any other condition that that young person is likely to come to with A&E. And yet, we still don't have that collective service available in the right way. And I'm not criticising, it's just a really sad state of affairs. So I think this is really good to promote that discussion about how can we make that experience more positive, how can we actually make this as an opportunity to provide the right care that somebody needs, rather than a negative experience, which I think for many it is. So thank you for that, and I do hope, and I've been challenging the things I've said, I'm aware of that, and I know it's an exception, not the rule, but it shouldn't be happening at all. So please do have those conversations over coffee around that. And now, any questions to Pooja and Molly from that project?
Just to say, Mark's here because he is one of the clinicians who helped with some of the setting up of this. So we've got a clinical question. We'll direct it there.
I'm also the national lead for A&E for mental health, so I'm the chair of the mental health committee. So, yeah, so if there's anything that you want to ask that's related to this from an A&E point of view, I'm very happy to.
Cool. So obviously A&E and general practice, like we are the risk specialists of the healthcare system. Like we make a lot of decisions in huge amounts of uncertainty. When I was in coroners facing the family, they're like, why didn't you do something? And it's like, I can't actually go into the full depths of like some of the complexity of the fact that we can't literally investigate, do everything every time. But when it comes to the mental health, like presentations and this feeling of risk, it's articulated, it's spoke about. Every time we discharge people from A&E, there's potentially some risk, but we really feel that risk. So what, and we talk a lot about, we're very focused on the individuals, but really what is it about our system that is so poor and terrible that the individual clinicians and these poor mental health nurses who are definitely not paid enough and are not banded enough to have that level of responsibility put on their head, feeling that they are personally taking that risk, and then we wonder why they're burning out, and then we have a coroner system that then, you know, it's on your head, and then they're pulled up in front of the coroners being made accountable as individuals, yet there's no system accountability. So the interaction of the whole legal system and how it perverts our like clinical practice, there's so much to this that is, language is so important, and I would say it's a bit better than that, but it's still not good enough.
I'm very glad to hear that
it's a little bit better, I'd say. But, you know, looking at the recommendations and things, it's very focused on, I think it's good we have individual system, local level recommendations, but what are our high level 10-year societal, you know, ambitions for this that comes out, that's definitely within your work and your insights into that. Thank you.
Well, interesting that you say that. So Professor Taj Nathan, who's at Cheshire Rural Partnership Trust and who also does a lot of work with the ARC as well, is actually leading on some research looking at this. So we did some research where we looked at clinical decision making on kind of admissions to hospital, and a lot that came out of that was the admissions being driven by people being worried from previous negative experiences if something had happened. And actually he's trying to lead on some research where we're going right to the top, kind of to really understand how we filter this down, and then how it becomes kind of a better experience for staff, that they're not kind of held accountable to the level they are now. So there's actually a framework that's just been put together, and we're looking at publishing this very soon. And hopefully that framework will be used in this way, that then that can kind of be taken, if you like, to a coroner's court and said, well, I followed kind of these kind of things, and to support staff, because actually it's a really horrible place to be if you do have that experience, and that experience is having a knock-on effect on decision making then as well.
So thank you very much, Pooja. Great point. I am going to move on because we are falling quite heavily behind time. Please do talk to Pooja, Molly, and colleagues about this, and I do hope that you can come together and plan some sort of A&E mental health implementation project. I think that was a real opportunity that hopefully today will foster, and it's great to have the national lead here. I wasn't aware of that, so unless there are things happening already that we can support through the ARC to enable them to spread, which is of course a great opportunity too, so I think rather than start from scratch.